I'm Jonah Comstock, Editor-in-Chief of PharmaForum. I'm here with Fred Turner, CEO of Curative. Hi, Fred.
Hi.
How's your show going so far?
It's going pretty good so far. Hectic and a little bit wet with all the rain, but good apart from that.
So tell me a little bit about Curative. You guys made a big pivot recently, very relative to the whole COVID thing, which is still on people's minds.
Yeah, so traditionally COVID testing has been our biggest business. We've done about 36 million COVID tests across, I think, some 48 states. So been a big part of the COVID-19 response with about 2.5 million vaccines as well. We've always sort of seen that the need for COVID testing, particularly at the scale that we were doing it at. We were the ones running the Dodger Stadium site in LA.
Okay, wow.
So, it just peaked 10,000 people a day going through that site. And the need for testing at that scale, I think, has largely subsided. So we, for the past 18 months, have been working on what's next for Curative, or what we call Curative 2.0, and have decided to launch a large group commercial health plan.
Yeah, so that is, I'm sure there's a connecting of the dots that makes sense, but spin it out for me.
Yeah, I mean, on the COVID side, we worked with every large insurance company, large and small across the US. I think about 12,000 different payers that we recognize and have billed for COVID tests. And so we got to sort of see behind the curtain of working with every single payer and how they're doing things. And as we're looking at, what can we do post-COVID that's going to make a big impact, everything you're doing on the provider side, you're limited by how fast the payer can move.
Right.
And so we wanted to build on the payer side, and specifically in the commercial space. Because obviously there's been a lot of new companies trying to enter on the payer side. Your Oscars, your Brights, maybe not gone particularly well, but those have largely been either exchange business or Medicare Advantage. And there's really been very little new stuff in fully insured large group commercial, which is where most people get their insurance from.
I mean, I suppose the argument would be that there isn't new stuff because the incumbent players are so big and so incumbent, right?
Yeah, but I think there's demand from employers and employees. I think the company we most like to be compared to is Bind. They popped up and grew very rapidly to a few 100,000 members, and then got snapped up by United. So I think they kind of demonstrated that employers are looking for something new, right? They're not happy with their existing offering, but there's just a very big moat from the large incumbents.
Is that a positive outcome for you to get snapped up, or do you want to really become a player in your own right?
Yeah, no, we want to build the next, United, Aetna, or Cigna.
Great. Well, it's quite an undertaking. So now that you are a payer, what are you doing at a pharma conference?
Well, we have to reimburse drug companies and PBMs, and those. Cigna presented yesterday. I think Oscar and Bright are presenting today. So there's a lot of payers here as well.
Yeah, it's
a
stakeholder
coming down the pipeline, right?
What are some of the things that you're going to do or you are doing to differentiate yourself from those incumbent players?
Our plan design is very unique. So the way the Curative plan works, as long as you show up within the first 120 days and do a preventative visit, which we call the baseline, with one of our affiliated providers, then you will have no cost sharing for the whole year. So $0 copays, no deductible, no co-insurance. Basically, you will not pay $1 for any in-network care for the whole year. So we call it Netflix for healthcare, right? You pay your membership fee, your monthly premium, and then after that, as long as you get that one preventative visit, it's free. If you don't get your preventative visit, you have a $5,000 deductible.
Interesting. So just really incentivizing that care. How do you make the financials of that work out?
So the thing with particularly deductibles is if you have, say, a $5,000 deductible, you're on a HDHP, that's not going to stop you from going to hospital if you have a heart attack, right? It's not going to help you shop hospitals if you have a heart attack either. You're just going to go to wherever the ambulance takes you.
Right.
So on those very high value claims, which is really where most of the money actually goes, the deductible isn't driving any actual meaningful change in behavior. What the deductible is doing is stopping you from going and getting that preventative visit that might have stopped the heart attack in the first place. And so when you put up patient cost sharing, there's a ton of studies about this now. What basically happens, you see a short-term decrease in cost. For about 12 months, you get about a 10% reduction in cost because people stop going and getting care. And so, benefits people, HR people then celebrate, yay, we've reduced the healthcare cost. But you haven't. All you've done is basically move it to future years where it's generally going to be a higher acuity. So you're shifting all that cost downstream. So by the time you get into the second year, you're back at baseline cost. And by the third year, you're well above where you would have been had you not shifted that cost onto the patient. Because people just put off care.
So this is another one of those misaligned incentives we're always hearing about.
Right.
The incentive it creates for the patient is to not get care when it might be cheaper and more effective.
Exactly. There was a great study looking at a group about 50,000 members going from almost no deductible to a high deductible. And what you see is colonoscopies go down a third, even though on the plan, colonoscopies are actually free because they're preventative. So when you tell people, oh, it's going to cost to get care, they don't bother reading the fine print that the colonoscopy would have actually been free anyway. They just don't bother getting it.
Yeah.
No one really wanted to get a colonoscopy. So if you give them any incentive not to, they'll take it. And then you see a marked increase in colon cancer rates.
Yeah.
Which is a lot more expensive, and people will die.
That's
so you want to
really
deal with stuff as far upstream as you can. And what we're trying to do is make that investment in people in that first year. And that's going to cost a little bit more. The first year, we spend a bit more money on people. But by the second and third year, they're healthier. So we benefit as an insurance company. So not paying expensive claims. The employer benefits because their employees are healthier. And obviously the employee wants to be healthy at the end of the day.
So the question that always comes up, I think, with new efforts in insurance is, are you just going after the young invincibles who have money and don't have health problems? Or is this a health plan that's really robust to the full range of individuals that might be covered when you start to work with a population or an employer?
Yeah, I mean, this is why we wanted to focus exclusively on the employer side, right? There's very few employers where you can cherry pick that they're only going to have young, healthy people, right? And our sweet spot is about 50 to 500 employees. We do some larger than that as well. But once you're above 50 employees, which is kind of our minimum floor, you're already getting that natural distribution.
Right.
And so it's very hard to sort of cherry pick groups.
So you can really prove out the value prospect.
Yeah.
So you're working with through employers, and any other paths to market for you right now? Anything, especially like the I guess like Medicare, Medicaid, the lower income, is that on your radar at all? Or?
No, we're trying to stay entirely away from that. Just focus on the large group employer.
Okay.
I think that's for us kind of an advantage. You've got the large health plans where really all their growth is coming from government business, right? Medicare, Medicaid, and so that's what they have all their best people focused on.
Yeah.
Who do they have focused on the commercial business? The people who didn't cut it for working on the Medicare business. And so we see this big opportunity where the group space just hasn't really been disrupted. It's not changed. The people working on it are just sort of viewing it as status quo will continue forever. And by focusing exclusively on that, not getting distracted by the government business, which is far more regulated, far more difficult to build anything new in, that we can really disrupt the employer space.
What about user experience? Health insurance it's pretty terrible on this metric. It's full of jargon that no one understands.
Yep.
Signing up for a plan is very difficult to do. You can only do it in a short window of time. And sometimes people aren't aware of what that is, what it isn't.
Yep.
And I know some of the startups on this side, you mentioned Oscar and et cetera, that's been a real differentiator for them. Is that something you guys are thinking about in terms of like consumer friendliness?
Yeah, it's definitely a key focus for us. So two things there. One, the plan design. As we're designing this, we were trying to think about what plan can we put together that people can actually understand, right? Because to the earlier point about colonoscopies and when they're free, people still don't get them.
Right.
If the plan is complicated, people are not going to read the fine print. They're not going to understand. They're just going to be like, healthcare, no, stay away, and they're not going to do the preventative things that we want them to do. And so the only plan we could come up with that we thought people could actually understand is $0. It's not going to cost you any money to go see care, and the network is broad, so you can go, pretty much anywhere. That's something people can get their head around, right? It's not difficult to understand. All you have to do is show up and get this preventative visit. And so the sort of plan is built around that concept of simplicity and how can we make this easy for people. The second thing is when you actually come in. Second thing is when you actually come and do your baseline visit, there's two components to it. So there's a medical component, but there's also what we call an onboarding component. And you do that with a assigned care navigator. And so this is someone who you can text, you can call 24/7, they're available. They're really there to kind of help you navigate the system. And at the baseline, they sit down with you and explain, here's what a copay actually is, here's what a deductible actually is, here's what it means to not have any, here's how you access the pharmacy, what the hell does in-network mean, and how do you find out if a doctor is or isn't in-network?
Yeah.
Right, and all the basic stuff that no one actually bothers to explain when you onboard to a health plan. Right, my personal experience being on several different US health plans, the best you ever get is a letter in the mail and it probably doesn't explain how to actually use your plan.
Yeah, there's a little bit of like passing the buck where they the payer says your employer's HR will deal with it. The employer's HR is way understaffed for the number of employees they have, and they you just go to the payer's website, and no one actually tells you anything.
Right, and so what that leads to is this lack of preventative care, because what we really want is that upfront engagement. We want people to engage when they're not sick so that we can keep them well, rather than waiting for them to end up in the emergency room.
Right.
And that decreases costs long term, but we have to drive that engagement to get there.
So, no deductible.
No deductible.
No copays.
No copays. No, really.
So the money is all coming from the I cannot remember the word for it, but the money that you paid up front and out of your paycheck every month. Your premium. Thank you. Premium. Jeez. JP Morgan day 3, everyone. So are your premiums insanely high?
Nope, they're comparable to United, Cigna, or Aetna premium.
Where's the money coming from, Fred?
From savings on keeping people healthier.
Well,
in that second and third year, the first year we spend a bit more money, but we absorb that because it's a fully insured product. And by the second and third year, keeping people out of the emergency room, keeping them out of the hospital, keeping them off expensive specialty drugs. Sorry, JPM. That's where the savings come from.
Well, I love this. It sounds great. It sounds too good to be true, but I'm sure you felt that way when you started off too.
Yeah, we were looking at, why has there been this increase in high deductibles, and what is driving that, and is this actually working? And you can look at the data. There's tons of studies on this now. I think it's fairly clear that the move to high deductible health plans is not leading to Americans being healthier. It's not actually saving any real money. You're just basically pushing stuff downstream and dealing with it later.
Before we go, we are at JP Morgan, and I do write for a pharma company. So let's talk a little bit about drugs.
Yes.
How do you, one advantage the big incumbent players have, obviously, is they've cut some big deals. They've got the volume to make big deals on drug prices. How is that for you as a new player? What's your thinking about the cost of prescription drugs and not getting sunken by that?
It's definitely hard as a smaller plan. We don't have that scale. To some degree, you also have some flexibility because we're not tied in to as many of the sort of deep convoluted rebate agreements that some of the bigger plans are tied into. So with Humira coming off patent this year, and nobody actually putting a biosimilar above Humira, but keeping them at parity. A lot of that's obviously driven by rebates on other drugs.
Yeah.
And we don't have kind of that same, deep rebate pool that has been built over a long time that restricts what you can actually do.
So more misaligned incentives that you're skirting around.
Yeah. We also actually own a pharmacy. So the way the Curative pharmacy benefit works is we have Curative, and then HEB, which in Texas is one of the largest grocery chains, is the pharmacy network, and we do free same-day delivery to your work or home. And having those scripts come through us lets us really guarantee that patients are getting their drugs at $0. So for every or almost every disease state, we have a option that is available at $0 out of pocket. But if you want one specific brand over another brand where there's medical equivalence, and we've determined that this is the brand that we're going with, having the other brand will be $50 or $250. And so we want to steer patients towards the $0 option, and by owning the pharmacy, we're able to really drive that steerage towards the preferred option.
So one last question. Where are you? How far along are you? Why haven't I seen it on the front page of every newspaper that there's a health plan with no deductibles and no copays?
So we're live now in Texas. Probably why you haven't heard of it in the newspaper. We have our first groups. We have our first few thousand members live in Texas. So we can sell to any employer who is based in the state of Texas. We can cover employees in certain states outside of Texas, but the employer has to be based in Texas. So we'll be looking to expand over the next year into other markets as well. But right now, it's just for Texas-based employers.
Got it. I remember that from covering Oscar, that you do have to get a lot of things done on a state-by-state level, which is a pain in the neck.
It's a state-regulated business. Yeah.
Well, thanks so much. This has been really interesting conversation. I'm glad we got to chat, and hopefully, keep me appraised.
Yeah. Thank you.